Grassley, Senator Padilla, followed by Senator Johnson.
Thank you, Mr. Chair. Just want to remind us that during last week's hearing, several of our colleagues discussed the impact of the American Rescue Plan's expanded child tax credit. It was nothing short of striking that the national child poverty rate hit a record low of 5.2% in 2021. That included a decline in the rate of Hispanic children from 14.7% in 2020 to 8.4% in 2021. That's something I think we're all proud of, both sides of the aisle. Recent census data shows, however, that many of these families slid back into poverty upon the expiration of the expanded child tax credit. Now, I can't help but notice that a lot of the Republican proposals for spending suggest delaying or reducing benefits that have been earned and are meant to be retirement security for older Americans. The poverty rate amongst U.S. seniors 65 and older is already nearly double that of the OECD average, and just 3 countries have worse income inequality among this age group. Question for Dr. Moon. What are the expected impacts of these proposals to cut Medicare on senior poverty rates and inequality?
Thank you. I think that the important thing to keep in mind here is that older and disabled Americans are like all the rest of the population, and that is there are some who have very modest incomes and some who have much more substantial incomes. But the number of seniors who rely upon Medicare and Social Security to a massive degree is much higher than many people appreciate. And for those with moderate incomes and not very far above the poverty level, because our low income protections for seniors are not that generous, this is a real potential burden. They're already paying a substantial amount, often more than a quarter of their incomes for their health care costs, for example, and further cuts in the Medicare program or further requirements for them to pay more would have a substantial impact. It doesn't always show up in terms of the formal poverty rates because we base that on income and not on Medicare, but people who look at the in-kind contributions that are made in alternative measures often note with alarm what would happen if you were to, for example, reduce spending on Medicare.
Thank you. Now, unsurprisingly, a lot of our Republican colleagues are focusing on cuts across the board in the budget, and Medicare is no different, focusing on cuts to benefits, cuts to coverage, and cuts to access. When I believe what we should be discussing is ways to preserve and build on Medicare's many successes. Now, efforts to strengthen Medicare and save on costs don't have to be mutually exclusive. For example, the collaborative care models is an evidence-based and cost-effective strategy for treating common behavioral health problems in primary care that remains underutilized. About 1 in 4 Medicare beneficiaries live with mental illness. I mean, that's the population at large. But only 40 to 50% receive treatment. It's also more pervasive in beneficiaries from American Indian, Alaska Native, and Hispanic communities. Now, the president's fiscal year 24 budget laid out a plan to extend the life of the Medicare Trust Fund while also lowering costs for mental health services. And specifically, it eliminated cost sharing for some mental and behavioral health visits and required parity between physical health and mental health coverage under Medicare. We knew mental health was a crisis before the pandemic. It's only been exacerbated and spotlighted by the pandemic. And since, Dr. Moon, how have these cost-cutting debates influenced the scope of Medicare coverage, including for mental health services?
I think that mental health is a good example, like a number of other benefits that have often been underappreciated. Home health was one of them for a long time. Hospice care is another example. And often in a zeal to cut costs, the notion is if we expand the services that are offered, they will suddenly be abused and costs will go up, rather than thinking about what the appropriate way to provide care is. I think that reforms that are aimed at improving the quality of care by making it the right care at the right time always makes sense and should always be an effort. And I think mental health would be one of those things. What you want to be very careful about is not doing, assuming that there are cost cutting that's less careful in terms of protecting the things that need to be protected.
So, thank you. And if I heard you, let me sort of rephrase for the folks back home, just as with physical health, treating mental health in emergency room settings is not the most cost-effective approach.
I totally agree with that.
Thank you, Mr. Chair.
Thank you, Senator Padilla. Senator Johnson.
Thank you, Mr. Chairman. Had I not read my schedule,